Hello, hello. Good evening, good afternoon, and good morning, whatever you're watching, from whatever part of the world you're watching. It's another day and another time for the Touch Yourself show. And I'm your host, Toyin Adeshola. And as usual, with me co-hosting is Maureen Wachi. Hi, Maureen.
Hi, Toyin. Hi, everyone out there. Hello.
Okay, so if you are watching on Facebook, please share and let people know that this topic is on. It's going to be an interesting topic. I know a lot of people come and ask me on my DM, and we get a lot of problems regarding this issue. So it's something that I feel you should be part of. So share, and if you're on our YouTube page, channel, like, subscribe, and also share to people so that they know what is going on. So today we're going to be talking about my bones and I, the challenges of a sickle cell warrior. Maureen, I know between you and me, we've had issues to do with bone issues and sickle cell. You having surgery, me having surgery many years ago. It's definitely a challenge. But I wanted to just
Types,
before I bring
different
it on
kinds.
now. Sorry, what did you say?
No, I said yes, bone issues, different types. Yeah.
Yes, different types. I think I've had the two major ones in my life. And they take some one of them takes a while to solve. The other one, it's body matters. So it's an issue that I'm glad we're talking about today. And so I'll be bringing on our guests on the show, and get Maureen to introduce them while I bring them up. And our first guest is Dr. Bolarinwa Akiola. Yes. Hello, Dr. Akiola.
Hi.
Hi, good evening. Good evening, everyone. Thanks for
Good
inviting me on this
evening.
show. And it's all the love, Sickle Warrior. Kudos to you all. Kudos to you all for inviting. Really appreciate it.
Thank you so much. Thank you. Thank you. Thank you. Um, so over to you, Maureen.
I hope you can
Oh,
all hear
okay.
me though.
Let me just introduce our guests, special guest of honor, if I may say it so. All right. Dr. Akinola, he's a consultant, orthopedics, trauma and limb reconstruction doctor, a fellowship trained arthroplasty and trauma surgeon. He graduated from University of Ibadan, proceeded thereafter to the UK, where he undertook his orthopedic training on the East of England rotation and was awarded fellowship of the Royal College of Surgeons of Edinburgh, Trauma and Orthopedics in 2015. After obtaining his certificate of completion of training, he underwent further subspecialist fellowship training in South Africa and the north of England. He also holds a master's degree in public health from the London School of Hygiene and Tropical Medicine. Dr. Akinola returned to Nigeria in April 20.
Okay. Maureen, have you frozen or is it me that has
And
frozen? Okay. Okay, I think Maureen has frozen again. Maureen, are you there? She's
revision,
frozen.
complex trauma, and limb reconstruction, deformity correction, and the management of bone and joint infection. He is well published and continues to be involved in clinical research. I'm not a doctor, so I'm not intimidated. Anyway, so welcome, Dr. Bola.
Thank you for coming, Dr.
Yeah.
Bolarama. Yeah, and when I saw the Royal
The plan
College
was
of
not to
Surgeons,
intimidate you,
I
but
went woof woof. because that is my father's area, or was my father's. My father was a fellow of the Royal College of Surgeons, so I just went woof woof on that. Thank you for coming again. So, and next we're going to bring in on our two warriors, our wonderful dogged warriors.
Thank you, guys.
The first, yeah. Thank you. The first person I'll bring on is Abolaji Ibrahim. She's the admin manager at Sickle Cell Advocacy and Management Initiative, SAMI. And the next person I'll bring on is usually also our co-host and the content creator at Sickle Cell Advocacy and Management Initiative. This time we put him in the hot seat. They're not co-hosting this time. Yomi Abayomi Oyelami. Welcome to both of you. Can you hear me? Oh, Yomi has dropped out.
Thank you very much.
Yeah, great to have you, Bolaji.
Yes.
That's one of the challenges we face during this internet thing, but we'll
Yes,
walk
thank you
through
very
it.
much.
We'll walk through it. Yeah. So I want to put the first question to Dr. Bolaniwa. Can you hear me? Hello? Dr. Bolaniwa, can you hear me?
Dr. Bola is still there. Can you hear us? I think he's back.
Okay.
Can you hear us now?
So I can hear you. I can hear you all.
Okay. Now? Okay, great.
Can you hear
me? Great. Yes, we can hear you very well. All right. I'll go with the first question. When it comes to sickle cell, this is a basic question I want to ask. Why is it that people with sickle cell have issues with their bones, and what are the major bone issues that people with sickle cell have?
All right, that's a question to me, right?
Yes.
Is that correct?
Yes.
Okay, all right. Thanks a lot for the question. So, I mean, I'm sure I don't need to say too much about sickle cell to all of you. You're well aware of the disease and what is involved. Essentially, there's several different kinds of bone manifestations that you can get in sickle cell condition, and all of them are linked to different pathways. So, for example, if you look at the vaso-occlusive crisis that many sickle cell people tend to experience from time to time, that in itself predisposes the bones to having bone impact. And so first of all, the vaso-occlusive crisis itself causes pain. So as part of the normal crisis that sickle cell patients go through, they can also have bone pain as part of that that they experience. But the underlying effect of some of the occlusive crisis is also resulting in things like bone infarct. And bone infarcts over time, I mean, they're quite common around the shoulders, quite common around the hips, quite common in the spine as well. And over time, those infarcts will eventually result in the condition that we're all quite familiar with, which is the avascular necrosis, which is one of the commonest reasons why I, as an orthopedic surgeon, tend to see people who live with the sickle cell condition. Also, in addition to that, because of that same vaso-occlusive crisis, you can have a situation where you have this hand disease where you get a lot of swelling around the hands, a lot of swelling around the feet, and it's very, very, very painful as well. That's also one other condition that can affect us that focuses around the vaso-occlusive crisis. And also you can have some soft periosteal bleeding, just some bleeding underneath the surface of the layer of the bone. which can also lead to swelling and pain. So that's for the vaso-occlusive crisis on the one hand. On the other hand, you have this condition of chronic anemia. And chronic anemia, which again a lot of almost everyone that has a sickle cell condition experiences, because the body is trying to produce red blood cells, the marrow can get much enlarged. And the problem is marrow is getting enlarged. The cortex of the bone, which is the strong part of the bone, is getting thinner. And as it gets thinner, it means the bone is not quite as strong as it should be. So as an after effect of the chronic anemia, you can actually have bones that are not quite as should be, and then they could be predisposed to having fractures that are due to any injury. So we call them pathological fractures. So that is the kind of second scenario where the bone can be affected. And the third scenario, of course, is bone infection. And we know that in the sickle cell condition, there's a predisposition to osteomyelitis. And so osteomyelitis tends to be the third kind of condition that can really affect the bone. So in a nutshell, these are the main broad three categories. The infarction that happens with the vaso-occlusive crisis, the thinning of the bone and the weakening of the bone that happens because of the chronic anemia and the marrow hyperplasia, and then the osteomyelitis that happens because of infection.
Wow. Okay. Maureen, are you as somebody who has experienced some form of, I'm going to ask you, put you on the spot, you've experienced some form of, can you hear me? Because I'm not hearing you, you're on mute. I caught you. I'm going to put you on the spot.
Am I on hot seat now?
Yes, now. Yeah. No,
Okay.
but because I want, so that you would I'll get a baseline for this question I want to ask. Now, I know you've been through at least one of the major challenges with leg ulcers and osteomyelitis. How has it been? When, first of all, what was your mindset when you found out you were having this issue, and how has it been trying to manage it before you now decided to go under, if I will call it, go under the knife?
Okay, so at first, it was a recurring issue. It was a recurring problem because I had it earlier when I was about 7 or 8, and it was treated drastically using antibiotics. So I didn't have any issues with that leg for a very long time till maybe sometime in 2016, and tried treating it again with antibiotics. So I remember getting very tired. One, the particular medication I was placed on was very difficult to get. So I was supposed to use it for 6 weeks at first. I remember after 4 weeks, I called the hematologist. I said, I'm tired of looking for this medicine every time. That I'm just tired. Can I just stop? And she said, 4 weeks you've tried. Okay, you can stop for now. Let's see what happens. And I think I had traveled. I went home. I was in Abuja when I was able to get it the first time. So I think I bought up all I found in a particular pharmacy before I came back to Lagos. So it was. So after that, she said, I think after 2 years or so, there was no pain, no nothing, no swelling, no, I didn't have any problem.
Yeah. Here we go. Let's walk.
So I was like, and she said to me, the doctor said to me, you have to see an orthopedic surgeon. I remember one, I was very scared. All this one that we hear gist about in this country, somebody went in for surgery, something went wrong, and things like that. And I remember my older brother he wasn't having it. I remember saying one day that I was going to Luth to look for an orthopedic surgeon. I was like, Luth, is it that place I always hear about? And I don't know, not to put Luth in a bad light, but I think those were part of the fears I had. yeah, I had fears like so I got to the point where I had to think, okay, so if something, what is the worst thing that could actually happen if the surgery goes wrong? If something goes bad, what is the worst thing that would happen? I think I had to psych myself that way before I was able to accept that, okay, let me just do this thing and get it over with and see if and that was just it for me. So
Hmm.
I think basically it was the fear, maybe because of our healthcare system here or something like that.
Yeah, I feel you. Which means brings me to asking Yomi because I know he's experienced the same thing. Yomi, between now and then, when you are going through your own challenges with your leg ulcer, do you think anything has improved in terms of treatments and all that? Yomi, can you hear me? Doesn't seem to be able to hear me. Yomi? It's gone out. Okay. Maybe Bolaji, I'll go to you. Now, you have had challenges with AVN for a
Yes.
while. Can you share your experiences so far in trying to manage? Because I've had, in fact, I don't know, I was going to tell Dr. Olarinwa, I think it's things have improved a bit in terms of managing, finding a solution to it. But back in my days, uh, when we discovered we had such a thing, it was either you fuse the new hip or you manage as you are. And the fusing was the option I had back then. But in terms of what you're going through, do you think there's more hope now, or you think it's just the same?
Uh, I would say I think both ways. It goes both ways. There's more hope, and then it is it is still just the same, especially with the fact that I have to sleep in a particular kind of position. I must not sleep in a particular kind of position. And then the challenges I have been facing with it recently, when I go to the toilet, I stay longer before I stand up because I have to be very careful when I want to stand up. And then the experience has not been a pleasant one. So, but there is hope. I just know that there is hope because coupled with the fact that I had an episode last year with it that I could not walk for like a week or two. I could not walk well. I had to walk with the use of a walking aid. So, and then I have been advised several times that I should go and have the surgery done. But I've just been the stubborn one that has not gone to do the surgery. So that is it. That's it.
Okay. Maury, do you have any questions?
Yeah, so Dr. Bola, I remember discussing with you sometime last year about a the possibility of doing something which might still be in your mind, but I would like to ask: is there a way to actually um, first, find out, have early onset of AVN, and maybe something like let me say AVN. I think AVN is more is more complicated. So is there a way to find out early onset of AVN and to mitigate against it, just to put a stop to it? I know now there is something called is it called decompression, which can help, but is there really an age, let me put it that way, perhaps an age bracket where we could say, um, for ladies, XYZ number of years, you should start checking, you could be prone to AVN, or Could it be associated with certain childhood trauma or something? I don't know.
Right. Thanks a lot, Mo. So the one thing I forgot to mention, which Tony mentioned when she talked about, is also leg ulcers. So leg ulcers are quite common as well. Unfortunately, ulcers with sickle cell condition is not. So we categorize ulcer as arterial or venous because the treatment of arterial ulcer is different from the treatment of venous ulcer. Unfortunately, or I don't know how to say it, in sickle cell disease, the ulcers are actually mixed. There's a mixture, there's a mixed picture of arteriovenous ulcers, which makes it way more difficult to treat. But of recent, myself and one of my plastic surgeon colleagues are able to find a way to actually treat people with ulcers. And we've treated one patient successfully, and I'm hoping that that's a treatment that we could try on more people who have issues with ulcers. But come to your question about avascular necrosis, I think it's a very important point because the thing is not every person that has a sickle cell condition suffers from significant AVN. And so the first thing is the more people we see, the more people I'm able to see in the clinic, the more I'm able to categorize into those who are likely to get AVN and those who are less likely to have AVN. And one of the things that can connect people to AVN is how often you get vaso-occlusive. And so, I mean, I've had to, and again, when you talk about treatment of AVN, you have to think about the stage at which the AVN was picked up. So the AVN already degenerative changes have set in. Non-replacement options won't really work. So when you have a degenerative hip, for instance, that you already have arthritis in the hip, secondary to avascular necrosis, then you have to be thinking of a hip replacement because no treatment really works as well. But if you can kill up early, yes, as rightly alluded to, cord decompression is an option. But for cord decompression to work, AVN has about 0 to 4 stages, 0, 1, 2, 3, 4. For cord decompression to work, you have to pick the person up at not more than stage 2. All right. Once it's beyond stage 2, then cord decompression is unlikely to work. And this is where screening might become very, very important because X-rays are not going to pick it up. So X-ray grade 0 is an AVN that is only picked up on the MRI scan, but it's not. You can't see it on an X-ray. But the MRI already suggests that there's AVN occurring. And so maybe one of the things that we, that is society we have to look at is how to have MRI screenings on a yearly basis, especially if we can identify the high-risk group among patients with a sickle cell condition. Yearly MRI screening so that we can AVN early, we can intervene early and try to slow down the process of degeneration. I have had to do a hip replacement in a female. That's the youngest patient I've done a hip replacement on because of sickle cell secondary arthritis. And you don't really want to be doing a hip replacement at that age, but unfortunately, if the joint is that bad, then that's the only thing that can work. That's the only thing that will bring relief to the person. So I would say there must be a discussion around regular yearly MRI screening, first and foremost for the most at-risk group, so that we can identify AVN early and we can go in and offer the cord decompression and slow down the process of degenerative changes within the joint that is affected.
Yearly MRI screening.
Oh my
Dr.
God.
Wala, you're just entering areas that we are fighting health insurance at this moment. MRI is pretty, unfortunately, expensive, and the average person cannot afford it. That is the reality. So is there a way, before I even come and ask your main question, is there a way that we can, I know what's the word, CT scan is a bit cheaper. Is there a way you can find out without necessarily going through MRI, especially with situations we find ourselves in?
So I would say that the alternative would be X-rays. As I said, MRI is more sensitive, but X-rays is better. CT scan is a no-no. It's a no-no because it's not as diagnostic. And number two, it's too much radiation. All right, we don't want to be exposing people to radiation if we don't have to. MRI, there is no radiation involved. CT scan is a whole lot of radiation. But the other thing I would suggest is that as part of a lot of companies' corporate social responsibility, there's no reason why, if the societies approach some of these big diagnostic centers, they have downtimes. And when I say downtimes, they don't run 24/7 services, most of them. And there are quiet times like, we could all, the society could negotiate and say, maybe on the weekend, on the Saturday, Sunday, between the hours of 8 p.m. 11 p.m. or 8 p.m. and 10 p.m. as part of your CSR, why don't you offer discounted MRI services to people who can't ordinarily afford it? And unless we ask, we don't know what's possible. Do you understand? And I feel that an MRI that goes for 80,000, maybe with a little bit of discussions and persuasion, may go for as low as 15,000, possibly. The discussion has to be had.
Yeah, you're right. I was already going, Nigeria money, what? There's not the, as I said, the worst that can happen is a no.
Yeah, the worst that can happen is a no. Okay, so I would like to ask
Exactly.
Dr. Bola.
The worst that can happen is
Okay, so you mentioned people who may have crisis frequently, being prone to issues like this. What I think there are still quite a lot of people like Bolaji here who rarely have crisis, or maybe not the visible kind of crisis. Now that I think of it, not vaso-occlusive crisis, or I don't know what's going on there. So, but I think we have people like that who rarely have crisis, but still come down with these um, issues. So, at what age would you advise parents? I'm sure there are still parents who can afford, perhaps even if it's biannual MRI or 5 years and all that. So, at what age would you advise that?
okay. All right, thanks for that. So the cardinal, so sorry, I know that there's some questions on the chat group, which would be nice for us.
Yes, we're going to show them.
The cardinal,
Yes.
Yes, you would answer those
so
ones. Yes.
feature of avascular necrosis. All right, cardinal feature of avascular necrosis is pain. All right, and the moment the child, so what we shouldn't do is just think that every bone pain is just crisis pain. If you have avascular necrosis that is symptomatic, it will cause pain. And once you start having current pain around the joints, particularly the hip joint, the shoulder joint, sometimes the knee joint as well, sometimes the spine, then the minimum is to get an X-ray. If the pain remains persistent, then one gets an MRI scan. If you want to start doing so, this screening that I'm suggesting is not something that is being done at the moment. It's not being done anywhere in the world. This was something I was thinking about the other day, and I'm thinking, how can we? So if we're going to start a screening program using the MRI scan, then I have to sit down, or people have to sit down, medical professionals have to sit down to define very clearly the criteria and how best to do it. The good thing is MRI does not involve radiation. So to a large extent, apart from the claustrophobic nature of the machine, to a large extent, it's without significant side effects to the people going through it. But we don't have the criteria well developed yet. It's something that we can sit down to look
Okay.
Well,
So
okay,
I think
Yomi.
something we'll talk about much later.
Yes, exactly. Exactly. Yeah. It's a let's try and answer questions before we go. I know Yomi, I wanted
Yeah.
Yomi to share
Let
his
me
experience,
let me share
but
this one
let's
on the
answer.
screen. So,
Okay.
Dr. Bola, I believe you've met this person. It's like she's attacking you here. Okay, so he said, I remember you saying surgery for osteomyelitis isn't 100% certain it won't reoccur. What are the chances of complete healing on osteomyelitis? Is a setup, Abby? What are the chances?
All right, thanks for that. So, it is tough because unlike non-sickle cell affected people in the population, sickle cell itself, because of the chronic anemia and everything else, predisposes to osteomyelitis. So even if we're able to fully cure osteomyelitis in one part, it doesn't mean that you can't get osteomyelitis in another part. And then how well you effectively cure osteomyelitis depends on where it is as well. So ideally, what you want to do is resect that area of infection. You can't go resecting some major bones. For you have osteomyelitis in the tibia, you can't really resect the whole of your tibia without finding something to replace it with or something to support it with. So sometimes location as well may be tricky in terms of clearing it. But in terms of chances, I think if you have a well-structured approach to chronic osteomyelitis, which is what I'm focused on now, if you have a well-structured approach and you're meticulous and you can be patient about your treatment, I think there's a good chance of having a 70% cure rate for osteomyelitis if you're very meticulous and structured in your approach. Yes.
Wow.
Well, I would say 60 well, let me say about 60% cure rate, but I don't want to tie myself down to a number. Every case is different, and it also depends on how long the problem has been going on for.
Exactly. Every case is indeed different. I know I had about several at different times in my life, and the longest one I had was for 3 years, non-stop. So I know that different people's experience with osteomyelitis exists. But is there a way that we can I know we say blood clot veins and all that stuff. Is there a way we can limit the number of times we have this issue? Is it too much standing? Is it what we eat? Has nutrition got anything to do with it? Because sometimes find people in less favorable economics tend to even have it harder than others.
I agree. So most problems in the world have been shown to be to have a worse outcome based on your socioeconomic status. So if you fall into a group where uh, you clearly don't have good access to healthcare, to quality nutrition, to quality education, all of those things have a detrimental effect on the quality of of your life essentially, and then it also affects how well you're able to cope with disease conditions as well. I think basically sticking to a balanced diet, not anything with levity. So one of the problems is you really shouldn't have half treatment. So if somebody is poor protection and there's an indication to have antibiotics, a full course of antibiotics should be taken. Not I only take it until the pain gets better, then I stop taking it. There are times when you really need to go in and perform surgery, even if it's minimal surgery, to reduce the pressure in the bone to let out the pus. It might not be big surgery, it might just be little surgery that is needed. But the problem is sometimes some of these long-term effects are because of poorly treated index cases. So when it started happening, we didn't have a full and proper treatment. So it lingers and it lingers and it lingers. So those are some of the things that account for it as well. But I would say that maintaining as healthy a lifestyle as possible, knowing those things that trigger the crisis, or knowing those things that make your pain come on, and trying to avoid those situations as best as you possibly can. I mean, people have looked at the role of supplemental oxygen therapy. Some people have tried hyperbaric oxygen. I'm not sure if I'm not sure about the evidence behind those treatments, but home oxygen is available now, and maybe some people want to do a small trial to see if I give myself oxygen inhalation every evening, does it help? I don't know, so don't quote me on that. But something that is worth looking at the literature and saying, would it help generally? We know that some chronic wounds will do well with high concentration oxygen treatment, but the evidence is not 100% yet.
Okay. All right. Before Maureen takes the next question, let me quickly ask Maureen, Yomi, because I know you're going on and off. From your experience with Legos, were there anything that you did that helped it heal faster? Yomi, can you hear me? It's off. Okay, Maureen, over to you.
Okay, so there's a question there, but from Lola. Hi, doctor. Is it advisable for someone to live with AVN, especially if the joint has been diagnosed at stage 3? What are the consequences of not having the surgery done?
What I always advise people is that I think you should delay hip replacement surgery for as long as possible. All right. It definitely makes my work easier because the longer you leave it, the more difficult it becomes to do as a surgeon. But a hip replacement doesn't last forever. Okay. At the moment, we say that if you look at many of the published evidence, you tell people 10 to 15 years for a hip replacement before you start thinking of having another one. That doesn't mean that some of them don't last for longer than that, and it doesn't mean that some of them don't last for less than that. But the ballpark average figure is about 10 to 15 years. So imagine a 15-year-old that I did a hip replacement for, and the hip lasts for 15 years. At the age of 30, she's needing another replacement, and that one still lasts for 12 years. At the age of 42, she's needing another one done. At some point, it then becomes difficult to keep doing this replacement because you don't have as much bone to keep doing the replacement in. So I would say that if you're at grade 3, definitely degenerative changes have set in already. You already have what's called subchondral collapse, and therefore the only thing that can really help at that stage is a hip replacement. I'm assuming we're talking about a hip here. However, as long as the person can control the pain, as long as they can control the pain with painkillers, they can use a shoe race to maintain their leg length difference because you will have a leg length difference. As long as they can do those things and they are able to cope, they may even start walking with a cane or a walking stick. As long as they can do those things and they are able to cope, I will say delay it for as long as possible. But when you become dependent on painkillers, when you can get a good night's sleep without having to wake up because of pain, then you're getting to the point where you should be having the hip replacement surgery done.
Okay, so Lola is also asking if these hip replacement surgeries fail with sickle cell patients.
Sorry, I didn't get that. Can you repeat that?
Oh, okay. So Lola is asking if hip replacement surgeries fail with sickles. When it comes to sickle cell patients, do hip replacement surgeries fail?
Yeah. Okay. So my experience of so hip replacements can fail in anybody, not just in sickle cell patients. Hip replacement surgery can fail in anyone. As I said already, there is a natural lifetime or lifespan for a hip replacement. So if your hip replacement has exhausted its lifespan, I won't call that failure. I would just say that has exhausted its lifespan. But in terms of things going wrong with a hip replacement and not going well, in sickle cell like that, it can happen in any other person that has a hip replacement. But in sickle cell, it's even more difficult because the bone is quite sclerotic because of the bone infarction. So, but and then the risk of post-operative infection is on the high side as well, much higher than the average population. So you have to take a lot of precautions before you do hip replacement, and then you have to take a lot of precautions afterwards. And then you have to be prepared to go back in to do a washout if the person develops an early infection. You have to prepare to quickly go back in and do a washout just to make sure that you try to avoid infection as much as possible. What I will say is hip replacement in a sickle cell patient it's quite a technically difficult surgery. And so you just need to make sure that to reduce the risk of complications, you make sure that your surgeon has got experience doing hip replacement in sickle cell condition and not just somebody who is just starting off doing hip replacement because it can be very technically challenging. So you just need to make sure that your surgeon has experience doing that. But if you take all the precautions, so my practice, for instance, I would insist that people have an exchange blood transfusion before we even start because I want to reduce the risk of crisis, I want to reduce the risk of pain, I want to reduce the risk of infection. So I'll insist that people have an exchange blood transfusion before I even replace their hip. And then after replacing with good hydration, good pain relief, and then if I spot any hint of infection, I have a very low threshold to take that person back to the operating room and wash out the hip, and after that they tend to do well. I've done a number of sickle cell patients from my personal experience who have had hip replacements done, and touch wood, they're all doing well at the moment. So yeah, so it can go well. You just have to make sure that you take certain things into consideration when you're doing that.
Okay. I'm going to put you, Dr. Bala, I'm going to put you in a bit of a spot here. If you are willing to disclose, that is, what is the average cost? Because I know of people who have either gone to India to have it done, or they have it abroad somewhere, and all that. I even know somebody who even brought somebody from UK to do it here. Unfortunately, it failed. But what is the average cost of in Nigeria? That is of a good hip replacement, bearing not too many difficulties.
I think it depends on where you have it done. So public hospital or private hospital. Public hospital is always going to be cheaper. Now the public
Mm.
hospitals have good surgeons as well who can do these surgeries. The private hospitals can have good surgeons. So I think that average cost of a hip replacement, I would say that we're thinking about around the 2.5 million mark for a well done hip replacement. It might be slightly higher, it might be slightly lower, but I would say
Mm.
between around 2.5 million will be the cost in Nigeria. And remember that the quality of your implants matter as well. So the implants are produced in different parts of the world, and different surgeons have different thresholds for using implants from different parts of the world. Some of us have a predilection for using European or Western implants, not because we love the West that much, but because there's been lots of publications over time to show that these implants are tried and tested, and they survive the time span that you expect it to survive for. The problem with some of the other countries is you may not get enough information to say how good these implants are, how long it's been used for, what's the survivorship of the implant. So I think any implant has a track record of good survivorship, then should be useful. In this time when the dollar we don't really manufacture anything, these implants in Nigeria. So because of the exchange rate
Yeah.
that keeps going up and down, that's one of the things that affects the cost as well. So, but I'll say in the range of 2.5 million is what it will cost to get a good replacement.
Yeah. Mm. Yeah. I figured it'd be that much. But is one of the things I learned when it comes to, and I'm not giving it, but I know there's some challenges that people have when they do the surgery is post care. I say a lot of time that emphasis is laid on the pre and the actual surgery, but they don't reflect on post care. And I've seen people get into challenges because they didn't bargain for post care. They were not told about post care, or they were
Yeah.
not told that they need money for post care, and they run around looking for extra money that they didn't plan on, which includes physiotherapy. So how can we get more medical personnel to talk about post care when it comes to all these kind of surgeries?
Sure. So you're very right. Post care is important. Maybe the reason why people don't focus a lot on post care is because it's not money you pay all at once. If you're going to go for physiotherapy, for instance, you kind of pay session. There will nobody people say, "I come and pay 1 million for physiotherapy." You can afford to pay per session. But yeah, post care is very important, and I can say very confidently that the quality of your pre care and the quality of your intra care also has a bearing on your post care as well. But post care is very important, and especially from what I've highlighted here, where I said if a patient with sickle cell ends up having a hint of infection, there should be a very low threshold to take them back to the operating room to wash them out, to make sure that they don't have a long-term infection. And those things attract the cost. The only difficulty is that, so when we look at complications in surgical care, you look at patient factors, you look at surgery factors, you look at implant factors. Now, the higher risk of infection post surgery in the sickle cell patient, a lot of it is patient factor. So what you now need to do as a surgeon is to make sure that you reduce those factors as much as possible before you even do anything. But yeah, I agree with you. People educated about the likelihood of what they would need to spend after their in-hospital treatment. That's very important because physiotherapy is important as well. Definitely, it is important. It makes a difference in how well people are able to enjoy their hips or their joints after surgery has been done.
Yeah, exactly. Yeah. Well,
So
we're almost out of time, but over to you, Maureen.
okay, so I'm going to ask two questions. One is related to the last one. Yes, it's apart from being told about post care, I'm sure some doctors do. I remember when I went round to three other places before I went to Cedar Crest. Was I told? I think only one place I was told that there was going to be need for physiotherapy and all that, and I was told the same thing at Cedar Crest. But the other two places they didn't tell me. But besides that, I want to ask the 2.5 average you talked about earlier. Does it include this post care we just talked about?
No, it doesn't. No, it doesn't.
Ah,
No, no, it doesn't. Because you also have to remember. No, it doesn't. I'm gonna be pretty frank and open with you. No, it doesn't. Okay, no.
okay. So, um, okay. Well, like, before I ask my next question,
But
I
let
want
me
to
tell
say,
you. Let me tell you. But just
okay.
very quickly, I just want to say that one of the things that can help, all right, one of the things that can help is And I think the societies should be looking at this. There's no reason why societies can't run its own hospitals, all right, where people can dedicate their time. If, for instance, I come to a hospital set up by one of the sickle cell society, and all I'm doing is bringing my skill and bringing the implants, right, and saying, okay, I'm going to come and do this surgery. The patient can pay for the implant, and I can say, well, yeah, let's do this for charity, right? You don't need to pay me. For instance, I'll just do this for, as they say, for Jesus or for Allah, I don't know. And then in that situation, it reduces the cost. But when you're going to a health facility, and the truth is, if the society set up their own sickle cell society hospital, they can keep costs really down for the beneficiaries. And the people that come in, they can come in at very reduced cost as well. And that can keep costs down for your patients who need the surgery fund. If you have to go out to the private hospital, unfortunately, it's going to be that expensive. But if you have your own centers where you can equip it and have nurses and have doctors, and everybody knows that they're just doing this as a humanitarian thing, then that can help to keep costs down. And it doesn't have to be a big facility. It can just be like a converted duplex, and that can serve a very, very, very good function. We need to just think outside of the box a little bit.
Yeah, you're right. Okay, so my next question and last question for tonight is June 14th is we'll be celebrating what we're commemorating World Blood Donor Day. So, how important is blood towards the kind of surgeries you handle? I know for leg ulcers, some people, or there have been some claims that blood transfusions can help. Even exchange blood transfusions can help heal leg ulcers. And I know perhaps during surgeries, depending on the kind of surgery, not everybody needs blood. But how important, especially with these kind of delicate surgeries, when it comes to people living with sickle cell, how important would you say it is?
Oh, very, very important, because I said it earlier that when I'm going to undergo surgery, I actually, and we have a policy in my hospital of doing an exchange blood transfusion before we even do surgery, because we want to replace as many of the sickle hemoglobin with good hemoglobin before we even start, to increase the oxygen carrying capacity, to reduce the risk of crisis. The thing is, in sickle cell, there are two issues. Number one is the blood loss that happens during surgery. That's number one. So you do get blood loss during surgery. Number two is also the oxygen carrying capacity of the sickle blood, which is not as great as as the hemoglobin A, for instance. So because of that, it's very important to try and optimize both the oxygen carrying capacity of the blood as well as the blood volume. So there are things we do in theater to reduce blood loss. There are things you can give, blood products, not just blood actually, blood products just to keep up the blood volume. But when it comes
Yeah.
to replacing blood loss, you have to replace that. But importantly, in sickle cell, you also have to optimize the blood carrying capacity, which is where DBT becomes important. In terms of leg ulcers, I actually think that I'm not too sure about the evidence between transfusion and leg ulcers. What we have started doing that we think was is to debride the leg ulcer. So take the person to the operating room, clean out the ulcer, send the sample of the tissue to microbiology to see that most of the time there will be some overlying infection as well, or some underlying infection. And then we use what is called the vacuum assisted therapy, all right, where we basically use vacuum to improve the quality of the tissue bed. So we use that vacuum assisted treatment, improve the quality of the tissue bed, quality of the tissue in preparation for skin grafting. And that sequence of debridement, antibiotics for infection, vacuum assisted therapy, and then skin grafting is something that I have seen has worked really well, and we're hoping to have more series just to give people a different option to treating the leg ulcers.
Interesting.
Yeah. Well, it's been an interesting discourse. I'm sure we could go on and on because this topic is very wide. There are more and more information we need concerning this area. Olaide is saying that Dr. Bola should please work with Sammy to give us a discount on surgeries. Olaide, we'll see about that. You don't want to put Dr. Bola under pressure. I'm sure he's not working on his own.
I'm very happy to.
Sorry, what did you say?
I'm very happy to, but I think the more I think the societies could have, even if it's once. I said I'm very happy to do that, but I think the model where the societies actually have just a treatment center, a well-equipped treatment center, and I'm sure there are many people out there who will be willing to sponsor it. I think that will help as well to reduce costs.
Yeah, we already talked about that last year, right? We're supposed to talk more about it this year. Funding is the major issue, and then we'll find a way around it.
Yeah, we definitely have to find a way around it because it's still something that is needed. I remember the issue of I think it was that ship that they have doctors who come and volunteer and they just bring people and they sort out everything. I think it works better that way. You get a lot of things done. Then there's even sometimes that you bring people from outside to come and do that. But as you said, there's a lot of a number of income involved, capital involved, and then of course government regulations. That's the word I'm looking for. That one has to deal with. But it's something that is doable. I believe nothing is impossible.
Yeah.
All right then. Thank you so much. So sorry, Yomi. I don't know. Your network seems to have failed you today. But any last words from you, Bolaji, before we go? And Yomi, if you can finally hear me. But first, Bolaji.
The only question I would like to ask is, what advice would you give someone like me that has been managing AVN for 24 years now?
Well, you were supposed to go and see him this year. Oh. June has ended.
June has out. Your secret is out. I'm sure Dr. Bola will mind giving you a quick consultation. So go and see him. Going to see him doesn't mean you're doing the actual surgery. Just going to see him.
I didn't hear what she said. What did she say?
She said, what advice would you give someone who has been managing her AVN for 24 years?
Oh, okay.
That was the question. If your own is 24 years, what about
sorry, I'm very happy. I'm very happy to. I think you're doing great. You're a real warrior. 24 years of AVN. That's not easy.
Yeah.
You're doing great. I don't my heart to you.
Okay, thank you.
Exactly.
But I still need to come in and see you. Yes.
Exactly. So, Yomi, any last words?
No problem. I'll be very happy. Very happy to.
If you can hear me. Okay. Yomi, can you hear us? Seems that he's out.
Yes, I can.
Okay.
I can hear you.
Finally. Your last words.
He's out
He's
again, so we have to. Yeah, we have to wrap it
Yeah,
up.
thank you so much, Dr. Bola. Thank you, Bolaji. One thing for sure is that do not keep your problem to yourself. Seek a doctor. It doesn't mean you went to see the doctor that you would already pay huge money. You may have an alternate. So don't be afraid to go and see your doctor, please. That's the most important thing.
Yeah.
I'll hand over to Maureen as she closes out.
All right. Thank you, everybody. Thank you, Dr. Bola, for being
Thank
here
you.
today. Thank you, Bola G. Thank you, Yomi.
Thank you.
I'm sure you'll be watching from the other end. So thank you, viewers at home. It's been an interesting session yet again. And we'll be back here next week, same time. And don't forget, next weekend is World Sickle Cell Day. And we'll be having some form of town hall meeting. Yeah, and Dr. Bola will be back on the show next week. So don't miss it. Make sure you get your friends and family to be on the show next week. So till we come your way again next time. If you are in Lagos, catch us on Wednesday, star 101.5 FM. And you can always watch the repeat of these shows on our Facebook page and YouTube. So thank you, everyone. Do have a lovely weekend. It's a long one.
And you too. Yes.
I don't know if Dr. Bola has a long weekend, but enjoy the rest of the weekend and have a great week ahead. Oops, never happened.
Bye.
Bye. At the right moment. Bye, everybody.
Bye.
Bye.
Appreciate it.